Good afternoon. Today, what I'm going to talk about now is the use of advanced devices to eliminate type 1 endoleaks. I have no conflict of interests. The type 1 endoleak is a problem that develops probably for a number of reasons, whether it be poor device placement, poor planning. And it can be frustrating, particularly at the end of the procedure. Often we'll be identifying them instantaneously where we do see the endoleak developing adjacent to the proximal attachment or the distal attachment of the graft. At the time of surgery, really whether we can fix it depends on a number of things. Firstly, if the flow rate is high, then it probably is imperative that we are treated at the same anaesthetic or the same treatment stage rather than leave it. In those situations where there is slow flow, it tends to mean that there's no outflow vessel, and sometimes they can settle. Other times they can disastrously cause a rapid increase in the residual aortic sac and then cause problems. The use of a self-expanding endograft as a stainless steel, also the proximal extension use of cuffs or chimneys should be considered in the presence of a type 1 endoleak. At a later stage, when the type 1 is found on subsequent ultrasound or CT surveillance, endovascular coiling of the endotract or endovascular fixation is an option for us. For type 1 endoleaks, we don't tend to use and employ a direct puncture of the residual sac, sometimes by their nature, but other times because it's difficult to ascertain whether there is a type 1 or a type 2 endoleak, particularly in those endoleaks prominent at the proximal end of the attachment. So can they settle? Well, the answer is yes. In the initial stages, a final run can demonstrate this, where we see a small type 1 endoleak, but you can also see that the contrast is hanging around and at no stage does it dissipate. In this situation, we use a gore excluder graft, and in those grafts, there's an expansion within the neck attachment that continues for 24 to 48 hours after the initial deployment. Subsequent ultrasound in this case demonstrated that the sac itself had settled down. It's important to note that this is unusual. Type 1 leaks don't tend to settle down, but in a situation where you feel that you've landed the graft in the appropriate space and you're confident with the measurements and there is appropriate sizing of the graft and post-deployment ballooning, I think it's reasonable to expect that a type 1 leak of this type would settle down. The difficulty is when it doesn't settle down and it obviously looks like a failure. In this situation, the graft has unfortunately slipped back in the presence of a tight, reverse funnel-shaped calcified neck. We can see here that the graft itself is deployed and is actually gone and extended within the substance of the aneurysm. The first instinct is to insert an aortic cuff, and in this situation we did that. But unfortunately, with all aortic cuffs, sometimes it can reproduce the exact size of the graft that you've already inserted. I mean, for that example, that when the aortic cuff is the same size as the graft neck, you often get the same result. Fortunately, in this situation, we deployed a smaller size aortic cuff, particularly in that area, to try to get some fixation of the neck. And initially that looked quite good. The cuff was inserted in the correct area. But as you can see here, the endoleak persists. So what's the next point? Well, the next situation then becomes whether we can make a more proximal cuff that's essentially a fenestrated device. In this situation, we've used fenestrated devices in the past to repair type 1 endoleaks. It's a very complicated procedure and technically challenging. In some grafts, for example, the restriction in the size of the body means that a fenestrated endocuff or a fenestrated graft more proximally is quite difficult to deploy accurately. We use a Cook-Zenith graft in this situation, and as you can see, there were 3 fenestrations and a branch component. Both fenestrations corresponded to the origins of the renal artery, and a larger fenestration at the origin of the SMA. Because this patient had a narrowing at the mesenteric level of the vessels and a dilatation of the distal lower end of the thoracic aorta, we decided to use a branch. One of the deployment problems in this particular individual was that she had an occluded left subclavian artery. So to deploy this graft and the branch component required a second procedure. So as you can see, we've been successfully able to deploy the graft with the stents in both renal arteries, a stent at the origin of the fenestration of the SMA, but there is leak because this image doesn't demonstrate that we've been able to fix the celiac axis at this component, but that's for a subsequent procedure. Interestingly enough, we've been able to cure the type 1 endoleak, which was really the aim of the initial procedure. We can employ an endo anchoring technique, which is very useful because what it does is it recreates the neck. In this situation, which is a slide I showed at the beginning, the CT confirms the presence of a type 1 endoleak. We can see that here, and we can see that the graft itself is actually landing quite close to the origin of the left renal. So realistically, there was no way for us to get any closer apposition. The problem in this case relates to this area here, calcification with angulation, and that created a dimpling effect. So the employment, we decided to use this case an endo anchors. Endo anchors are very useful. What they do is screw into the wall of the aorta through the fabric of the graft. In this position, in this technique, we've employed the use of an Altis, which is a steerable angulated catheter where the endo anchor comes out. Essentially, you curl the catheter like that and push it against the fabric and let the screw into the graft itself. It's a neat little invention and very useful. But you've got to be careful where you deploy the grafts, because whether you deploy the endo anchors, because unfortunately in some situations you may pucker the graft up, rendering the procedure a complete failure and being unable to repair the type 1 leak. As you can see in this situation, we have extended the graft with a cuff, which we've showed earlier, in the correct position, and we've strengthened that attachment by placing endo anchors at the 12, at the 9, 3, and 6 o'clock positions. The result is we've been able to successfully get a seal where we've been able to fix the cuff in this area here and get appropriate apposition against the wall and remove the endoleak. In this situation, it's a little bit more tricky. What we've done here is we've had to embolize a residual sac in a patient who had a previous endurant graft placed in. At the time of the original operation, the graft was settled, but unfortunately 2 years afterwards developed a type 1 endoleak and was noticed to have a contained rupture originating from that type 1 endoleak. Chimney grafts are employed. Now, chimney grafts in the initial stage are useful for those situations where we can't get a specific dedicated graft made, but they do create problems by creating a trough within the apposition and reducing the apposition of the extension piece against the wall of the aorta, and that's what happened here. So there was a gap between the chimney graft and the cuff, which was inserted more proximally. The result was that this patient had an ongoing type 1 endoleak. In endoleaks from the type 1, one of the biggest issues and problems we can have is if it's high flow and there's a rapid outflow vessel, coiling these types of grafts can be quite tricky. So if you come from the top, we can go down, interrogate outside the graft and through the gutter, and then we can place numerous coils and use a combination of a medication called Onyx. For those of you who don't use Onyx, it's used commonly in AV malformation, and it's become almost a standard of treatment that we use in place of coils for clinically significant type 1 and type 2 endoleaks. Onyx is essentially an ethylene vinyl alcohol. It's a copolymer that's dissolved in a thing called DMSO, and it's suspended in this substance called tantalum. It's a tantalum powder that we can see that looks black and provides all the artifact that we see in CT scanning. The coils in this situation are used to reinforce that blocked area, but in most situations, the Onyx is adequate enough. And this situation was successfully able to remove the type 2 and type 1 endoleak, and then subsequently the patient has been alive now up to 3 years. The problem that we have, however, with Onyx is that CTing is very difficult to perform, but also in the situation that we need to follow these patients up, we like to do this with an ultrasound. And the final option is an open repair. Now, in most situations, what we're talking about is for an infrarenal infrarenal EVA, but in some situations, we need to do a combination of open repair, branch device, deep branching of vessels that could assist in us getting a proper seal in the proximal end and allow us to make an appropriate assessment. So in this situation here, we're looking at a patient who had a thoracic graft repair. The lady presented in her 50s with a history of a type B dissection, a rapid increase in the false lumen size. So at that stage, a stent was inserted, which provided coverage initially, but as you can see from this initial CT scan, there was ongoing leak. And unfortunately, what happened in this situation was that the subclavian artery filled, and we were getting the classic situation of not covering the subclavian artery appropriately. I have to make some sacrifice, I'm sorry, to demonstrate the type 1 endoleak, but what we see here is that the origin of the left internal carotid artery and the brachiocephalic are quite close. So the plan then was to perform a debranching, which was done. The debranching was done here. It gives us the stump here for the origin of the original brachiocephalic artery, but also the origin here of the subclavian artery, of the left common carotid artery. So we debranched both the brachiocephalic and the left internal carotid artery to ensure we've got a proper seal. The main concern, obviously, in this patient, is that she had a chronic type B dissection, which made treatment difficult. And in this situation, the origin of the branch origin of the branch graft, the debranched component of the open graft was done quite more proximally in the ascending order, which gave us adequate neck to perform an adequate deployment of a more proximal graft, which allowed us to get sealing. We also did a carotid subclavian bypass graft, and you can see that we used an Amplatzer plug, which we used to plug that proximal subclavian artery to prevent retrograde flow. So in conclusion, type 1 endoleaks can be managed. They can be managed in a variety of techniques, but inevitably what a type 1 endoleak can reflect poor planning of the procedure. And I think the most common error that we make is that when we push the boundaries of the IFU. Sometimes you can pick it up by making ensuring a more proximal neck length is guaranteed, but overall, when you do develop a type 1 endoleak, it's not a complete disaster, and there are numerous possibilities and developments for adequate treatment. Thank you.